So now that we have come up with some concept of the individual, I hope that can help us plan our studies by addressing the complexities that of exposures and individual susceptibility that generates phenotypes and variations in phenotypes and variations in our science. We're going to talk about populations. So in the current state of technology, chronic multifactorial health states with complex webs of causation require population science to assist with untangling the web in order to operationalize diagnosis, prognosis, and treatment for populations and individuals. A complex statement. So what do I mean? So for these multifactorial health states, so here we look at cardiovascular death in the UK. This is an old graph, but it is a complex health state with many different factors along the life course that produce cardiovascular death. But here we look at water hardness of communities and the association with death from cardiovascular deaths. Now, if we just study one group, and I'm making the corollary just like we'd be studying one individual, you can't really determine this type of association. Maybe it's difficult to find or discover if you look over a very narrow range of exposure, so a short range of water hardness, and say this kind of cloud here. You may also have a difficulty seeing the trend or the association between cardiovascular death and water. But now if you take a big group such as this over a really broad range of exposures, only now are you really able to distinguish the association. And this is just one example of what I'm trying to say, that in terms of these multifactorial states such as cardiovascular death and many of the chronic diseases that are the number one causes of mortality today, it really takes large populations over broad ranges of exposures to really look at these types of associations or complex associations. So if we're studying populations, we need to define what a population is. So let's borrow from the Oxford English Dictionary. So by now in the semester, I imagine that some of the other MSCR classes, especially the statistics course, has gone over the statistical definition. And this is a real or hypothetical totality of objects or individuals which the statistical attributes may be estimated by the study sample or samples drawn from it. So essentially this statistical definition states that a population is the totality from which you sample from. And you can make generalizations to that totality using statistical techniques or mathematical techniques based on your sampling strategy, which we're going to discuss. And this is certainly a useful definition. It works extremely well with inanimate objects like coin flips or the rolling of dice, which has very limited amount of explanations of the outcome, but potentially is not a complete definition for individuals, which we see we just discussed are much more complicated. In genetics, a population is defined as a group of living beings in which breeding occurs. Maybe remember back to biology with the allelic frequencies of populations, the Hardy-Weinberg principle, and the driving of a natural selection. Also probably not as useful in clinical or translational research for many things. The general use, which is what we're going to borrow from is also a very broad definition as a group of people, especially a class or subset within a larger group. So really kind of a generic definition. So let's go into some more specific operational definitions of populations or types of populations pertinent to clinical research. So here I have a nested set of spheres to show the subsequent or consecutively diminishing or smaller subsets from a large population to ending up in a group of study participants for a study. We're going to go in these more detail, but a target population is generally the largest population, and we ask ourselves, to whom do we want our study or results to generalize to? The accessible population, we can't often study the entire target population, so what population is accessible to us in a feasible manner? From there, we have design a study or study procedures or selection procedures to produce an intended study sample from the accessible population. But then finally, participants or individuals ultimately decide if they want to participate, if they follow the study protocol to be included in the final analysis, and a follow-up at the end of the study. And so these become the study actual participants, so who actually completed the study. So let's go in these each in a little more detail. So the target population, this is the corollary of your general scientific question, like we talked about, I guess, 2 weeks ago now. It describes an ideal or theoretical population by characteristics that are relevant to the study question. So you're deciding what is important in the scientific question that I am asking. Now I say ideal or theoretical in terms of the population. Let me wait till the next slide to discuss that. The most important thing, just like in defining an aim for a study or an hypothesis, is to be as detailed and specific as possible in defining what you think is a true biologic phenotype when you're identifying a target population. From this general target population is where we devise our inclusion criteria. So who do we want to study? Here's an example. Adults over 18 years old with moderate persistent asthma on maintenance medium dose ICS LABA inhaler therapy with greater than 1 emergency room admission in the past year for an asthma exacerbation. So a very generic statement about, but still relatively detailed about who do we want to study, with some features in there that we think are relevant to defining a biologic phenotype. Now this general statement, from that we now devise more specified inclusion criteria, and I give some here, but we can be much more specific than this, but I left that out for space. So we get over 18 years old, very simple. Moderate persistent asthma now I say is defined by the National Asthma Education Prevention Program. So anybody can go look up this program. There's very specific criteria for defining this type of asthma. In the statement I said what type of therapy they're on, but you could really break this down in many different ways. Here I say currently prescribed. Now alternatively we could say prescribed within the past year, adherent to taking at least 75% of the doses in the past month. So you can even more specifically define what it means to be on this therapy. Again, there are also, in regards to this type of therapy, there is many different formulations, many different types. So you can create in the study a chart, a medication dose chart that really defines what it means to be on a medium dose inhaler therapy. And then finally, again, the ER visits. Now, here I put self-reported. Again, you could define that in different ways in your inclusion criteria. These could be adjudicated in a hospital record. Again, you can define it also as a different time period. Here I put calendar year. So again, from the generic target population, we define the inclusion criteria, trying to define a biologic phenotype of who we want to study. Let me go back. Now again, I said before the hypothetical or ideal population, and what I mean there is while this criteria can certainly identify a group or a population, that population, there is still enormous amounts of variation within that population. This sentence describing that population already oversimplifies all the different types of exposures, genetic backgrounds that each individual within that population defined by these criteria have. Therefore, there's no single one person or average person that this describes, but rather it does describe a group or a hypothetical group within which there are various amounts of individual variation, and that's what I meant by hypothetical or ideal population. But while this is sort of the generic who we want the study to generalize to, we are limited by geography, time, and resources to studying a population that's accessible to us or to the investigator. When choosing an accessible population, the investigator will always have trade-offs between feasibility on one hand and scientific concerns on another. And there's no way to get around that. The important thing is trying to make sure that you do not fatally sacrifice any science that would ruin or sink a study for feasibility. So there will always be a balance here, and just need to think about that beforehand to make sure you address or are able to scientifically get a reasonably representative, accessible population. When you're thinking about what is accessible, you should think hard about community versus clinical populations. You know, people who show up in a clinic are potentially already different from people living in a community who tend to be maybe healthier. Especially there's a certain type of selection bias called a Berkson bias, which is important to be familiar with. I don't have time to discuss it here. Wikipedia has a fantastic description of Berkson bias, so I would recommend you look at that. And then if you do a clinical population, to think about what center you're looking at. If it's your own, is it a referral center, and is there a bias in creating certain types of patients? And then community or clinically, you might want to think about the regional variations in demographics. If I were trying to create a study generalizable to the U.S. population, in the U.S. currently there is a minority Black or African American population. If I were to study in my own center at Grady Memorial Hospital, where the majority of all our patients are Black or African American, that regional variation would create potential problems and generalizability to a total U.S. population, if that were my target population. So sometimes the accessible population does equal the target population. This happens when your research question is extremely focused on a local population, when that target population is very well defined or circumscribed. So a isolated tribe in the Amazon, for example, again, that still be difficult to access, but that is potentially where you could study the entire target population if the size is appropriate. And another case example is in quality improvement research, where the research is really just interested in your own clinic or somebody's clinic or a certain practice. We'll talk about it later in the semester, but there is some debate about whether or not this is truly considered quote-unquote research, but for right now, we'll loosely define it as such. So we've discussed populations, and these are what are available. Now we're going to talk about sample. So a sample is a subset of a population, and the intended sample, sorry for the typo there, is what is specified by the study design. So the study procedures create the sample. There's non-probability and probability samples, and we're going to go over each. In non-probability sampling, I start off with exclusion criteria. So exclusion criteria identifies all the subjects that will not be studied, and generally these are made not for scientific concerns, but for practicality or safety or ethical concerns or feasibility. So here are some reasons: so lack of informed consent, of course, or cannot follow a study protocol or provide data. That could be a language barrier. It could be a cognitive barrier if some of the patients are in a coma or delirious. Maybe you exclude people with a high likelihood of being lost to follow-up, so they can't complete the study protocol because they have a high mortality condition, end-stage cancer, extreme old age, enrolled in hospice. Another reason is maybe there is a high risk of adverse side effects with the therapy or testing, contraindications to therapy, or the participant is on medications that could have interactions. Again, these aren't necessarily scientific concerns, but more practical concerns. When creating exclusion criteria, you want to be parsimonious, so as simple and as few as possible. Again, when we're creating a sample from a target population, when we have as simple and few as possible exclusions, there's a higher likelihood that our study participants or our intended sample is going to be, or is there higher likelihood to be more generalizable or representative of the target population. Try, if feasible, to design a study that reduces the number of exclusions. So if language is a barrier, you can maybe get translators, use a language line, translate the study materials. So try to implement design factors that reduce exclusions where feasible. A little bit of a soapbox note. So this is a quirk of mine that I include exclusion criteria in under the rubric of non-probability sampling. Some would include it more in the target population. The reason I do so is I think it is an important, at least in a concept of separating out a target population is what you scientifically want to study, and then an exclusion criteria create conditions that sample from that target population, and to be very upfront, clear, objective of those criteria and how it affects the generalizability. So usually the exclusion criteria are not just really separating these out that they're not scientific, but rather for other reasons and how that affects your intended sample. Okay, so some other non-probability sampling, convenience sampling, subjects that are conveniently accessible to the investigator. This is really common in secondary analysis, where potentially there's already a database available that you want to ask a question to. It might not have all the variables or have the exact target population that you want, but it's convenient. So this is good for pilot data. This is good for feasibility or proof of concept studies, for building in more exact studies. But of course, because of the convenience, often we have no control or little control over the accessible sample or the convenient sample, and so there can be subject to bias and generalizability because it's not exactly what we wanted or didn't have all the information we wanted. A consecutive sample, can be considered a subset of a convenient sample. This has to do with prospective enrolling, and this is what is often used in trials. It means you're essentially enrolling consecutive participants from the accessible population, one after the other. Really not a very useful concept other than just to name it, since it's often not named in studies is what they have done. When doing this, make sure you're considering whether a time period of sampling will affect the intended sample. So if you're doing consecutive enrollment of pneumonia patients, but you're doing it through the winter months, where pneumonia rates are the highest, and you need to be aware that pneumonia potentially has a seasonal variation, so that consecutive sample should include the entire range of variation in that disease process. Another thing could be enrolling consecutively Monday through Friday trauma patients, but maybe there are more traumas on the weekend. So you have to consider how the time period of consecutive sampling could be affected, could affect your intended sample. Okay, now we move on to probability samples. So these are statistical methods that are developed to generate a representative sample from a target population, or an accessible population, that is too large to otherwise study. These sampling methods, depending on the type of sampling method, produce design factors that can be accounted for on the back end in the statistical analysis to help produce generalizable descriptive estimates of the larger population. These try to rely as much as possible on random processes to reduce additional selection bias. So let's talk about some different types of probability samples. So the most simple is the simple random sample. And here, all of the accessible population is enumerated or listed, and a desired proportion is selected at random, either using a computer-generated selection process most commonly. This type of sampling can be, and is most often, probability proportion to size sampling. It's a type of random sampling, simple random sampling, where the probability of selection of an individual is proportionate to the size of, or the frequency of, that group inside the population. I'm going to do an example of that in a second. This design factor that this procedure produces is a weight, and that's a variable or an additional piece of information that can be attached to each observation or participant. It gets a weight, and this is often the inverse of the probability of selection. So let's dive a little deeper there. Okay, so we have on the left here theoretical accessible population with some different phenotypes. There's color, black and gray. There's dots or no dot or solids. We have the proportions here in the group. Let's just say we can't study the whole group, so we do 50%, so a random sample. So we select 50% of this group at random. Say we used a random number generator, and we produce this group on the right. So in general, if the selection is truly random, from the accessible population, we will produce proportions that are very similar in the study sample or the intended sample. Obviously this is a orchestrated or some example, but the general concept applies, is that we're producing similar proportions, a representative study sample that is representative of the accessible population that we randomly selected from. There's going to be some variability. It won't be exact. In this will be discussed more probably in your statistics class, but sample variability depends on the size of the sample. If you only take 25% in a really small group, more chance you're going to get variability. Larger samples will be more likely to be representative or have similar distributions as your target or accessible population. So let's talk about the weights here. So the probability of selection here, since it's a 50% sample, is your probability of each individual being selected is 0.5. The inverse of that is 2. So this becomes the weight that can be applied to the study sample to back calculate and make general estimations of the population from which it was sampled from. So for example, if we were trying to estimate how many cases of black solids there are in the total population, here we have 8 multiplied by 2, and we get an estimate. Again, it's not a perfect estimate, but an estimate of how many there were in the accessible population. So that's, again, a very simplified explanation of how weights are applied depending on your sampling and how they can be applied in the analysis on the back end. So another type of probability sample is the systematic sample. So here all of the accessible population is enumerated and a desired proportion is selected using pre-specified periodic process. So we take every third patient or every fourth patient, or we enroll every patient on every third day of the calendar month. This is really no major advantages over simple random sampling. There's just more convenience here. And there is subject to bias because there is certainly some non-random processes here. And in a clinical trial, investigators could potentially predict who is being selected for therapy versus placebo, and they could inadvertently or advertently introduce more bias in how those folks are treated. So I just name it here, even though it's not often used. So now let's talk about stratified random sample. So in this study design procedure, you divide the entire accessible population into strata, usually by some characteristic, males, females, blacks, whites, Hispanic, other study sites, so they're stratified by which hospital they were enrolled in. And then within each strata, you're doing a simple random sampling within the strata. So each strata gets randomly sampled from. This produces an additional design factor, which is the strata from which the individual belonged. So that operationally, this works differently in a prospective or clinical trial than it does in an observational study, or it's often used for different reasons. In a clinical trial, stratified random sampling or enrollment helps to ensure balance of certain variables, which may be important variables or variables of interest, such as a confounder. For example, say a drug company is doing a large randomized controlled trial. It takes millions of dollars, many years to perform, and they think that being male or female might have an important effect on how the treatment works. Now, if they invest all this time and energy, potentially, not likely, but potentially, when they enroll, they may enroll mostly males and less females, and that's just by random chance. That could happen. And you would hate to be on the back end of that study and be wondering why didn't we enroll more females, and you really would be out of luck. So instead, to preemptively make sure you have enough males and females, you may initially, any person who is screened for inclusion in the study, you may divide into males and females, and then randomly sample from males and females, making sure you have enough males and enough females to perform the study, so that on the back end you are ensured that you have the numbers that you need of each subgroup. And this could be important for confounders, but also in pre-planned effect modification analyses. And I realize that I'm not going to discuss what effect modification is now. That comes in a later lecture, but I did want to at least mention that here as a reason for stratified random sampling in clinical trials. In observational studies, there is often a different reason to do stratified sampling. This can allow you to do disproportionate sampling. So remember, we talked about proportionate probability sampling. Stratify can allow you to do disproportionate probability sampling. And what this allows is that you can divide groups on strata, and then you can oversample certain minority groups. This allows you to make sure you have a sufficient sample size of minority groups for creating or generating estimates. This does create additional design factors where each strata is weighted separately in order to apply appropriate weights and to the subgroups to make estimates for your general target population. So we produce a weights and strata. So let's cut to an example of this to maybe help. Okay, so back to the simple random example we just discussed, where you're simply selecting at random from the population. But in this population, there is a minority population or subgroup of gray dots. And if you just simply did a simple random sample of such a small proportion, you may end up with very low sample sizes. In this case, only 2 individuals in your study sample. And this may not be enough individuals to really make any types of generalizable scientific observations to that subgroup of the population. So to solve this, you may stratify your overall group by whether or not they're a solid or they're a dot. In those strata, you may then randomly sample, but at different sampling proportions. And there's nothing special about the 70 or 30 that I chose here. I just chose it. So now we do disproportionate sampling and we oversample the dots. So we sample 70% of the dots and we undersample 30% of the solids. And I use over and under because the proportions at which we are sampling aren't equal to the proportions that those individuals exist in their population. So what that allows is, in this small subgroup, we oversampled, and instead of producing 2 individuals, we produced 4. And for example, in the black solids, we undersampled, so there was 30% in the population, but we undersampled, and we get, in our study population, a lower overall proportion, but still sufficient to perform the study and make some observations. Now again, I realize the numbers on the right are pretty small still. This is really just for demonstration. You probably want more than 4 and 5, but just for teaching purposes to make the numbers small and manageable. So now, on the analytic side, each group has a strata, maybe strata 1 and strata 2, or dots and solid and dot strata. Each strata has a different weight applied to it that is, again, inversely proportional to the probability of sampling. So we sampled dots at 70% probability, so their weight is 1.4, the inverse of 0.7, and similar with the solids. So again, creates a little more analytic burden on the back end, but again helps you to ensure that you have sufficient sample size in your subgroups. Now often these different types of sampling are not used separately but in conjunction or together in a multi-stage or stepwise process. This multi-stage complex sampling is ubiquitous in the U.S. surveys, or the surveys of the National Center for Health Statistics here in the U.S. And the reason they do this is really for feasibility, allowing when you have a huge population like the entire U.S. That is unevenly distributed across large swaths of geography, really making it feasible to actually conduct an in-person study where the interviewers are traveling in buses and meeting individuals at their houses. To really perform that, you need some strategy. Of course, these multi-stage processes can produce very complex design factors, clusters, strata, weights, and increases the analytic burden, but decreases or increases the feasibility of conducting the study. So just one example, you may heard of the NHANES. This is the National Health and Nutrition Examination Survey. This is a publicly available survey. They conducted in 2-year cycles across the entire U.S. But just to give you at least a snapshot of how something like this is operationalized, they have a 4-stage sampling process of the U.S. So first, they take a big list of all the counties, and they do a random sampling of counties in a PPS fashion, proportionate to the size of the county or the number of population in the county in comparison to the entire U.S. population. And then within those counties, they randomly select in a PPS fashion the city blocks within those counties. And then in that sample of city blocks, they now do a simple random sample of households. And then finally within the blocks, they do a stratified random sample, stratified on sex, age, and race ethnicity. Again, this is a very complex real-life example of how to do an enormous individual in-house survey across the entire U.S. and trying to generate sufficient sample sizes in small subgroups of the population, ensure you have enough, but also creating a design that can be generalized to create entire U.S. estimates that generalize to the entire target population of the U.S. Finally, the last sort of nested group in our selection procedures, we have the study participants. So even though you've intended to create a study design, to create an intended sample, at the end of the day, the study participants are the people who actually complete the study or agree to participate in the study. And this is affected by your recruitment strategies, the ability and the willingness of individuals to adhere to the protocols and give data, and to complete the entire follow-up. So that is, again, one extra step of selection that produces a study group.